for reasons of efficiency, of cost, and patient friendliness. As family doctors, you should be building alliances. You should be building teams with nurse practitioners, occupational therapists, pharmacists, dietitians, and so on. They're not the enemy. They have to be your allies. But cost savings are only going to come if interdisciplinary care results in everybody working to their full scope of practice. That's the way we're going to cut labor costs, is getting people practicing smarter, not more. Currently, family doctors, like every other health professional, do a lot of stuff that can be done by others at a lesser cost. You have to let go of some of that stuff, and we have to incentivize that in the system. Now, you may not like to hear that, and many of you may feel that other health professionals are doing all kinds of things that should be the exclusive purview of MDs, that they're poaching on your territory, if you will. Well, I'm going to tell you bluntly that that's probably true, but that trend's going to continue, and it's going to continue for financial reasons, whether you like it or not. And by the way, I hear the same complaint from specialists. Oh, family docs are stealing our business. They're opening all kinds of specialized practices. Well, we're all going to have to suck it up a bit. Interdisciplinary care doesn't mean that nurse practitioners and pharmacists are going to replace family doctors. Not at all. It means you have complementary roles, and you have to find the proper turf and the proper division of labor. That's the challenge. But I think it's an obligation for you to make it work for the patient's sake and for the sake of sustainability of the system. Trend number 2 is a shift to community care and primary care. I think one of the biggest flaws in Canada's health system is that the front door is located at the wrong place. We don't really have a front door. By default, it's the emergency department. That's where way too many people end up, mostly because they don't have a primary care practitioner. The front door has to be primary care practices. That has to be the medical home, as the college said in its report very eloquently. The best healthcare systems in the world, those that are the most cost efficient, those that don't have waits, those that have good outcomes, place tremendous emphasis on primary care. That's the starting point of everything. We have to move in that direction, and quickly. Our current health system is too top-heavy, and it's too institutionally based. We don't have enough primary care practitioners or enough home care or enough long-term care facilities. We have to get people into the community. Today, there are about 7,500 patients in Canada who are living in hospital beds. They've essentially been discharged, but there's insufficient places for them to go, home care or long-term care, to accommodate them. This is just one example of tremendous waste in our system, of wrong-headedness. That's about $75 million a day. And I could list about 100 more examples like this of inefficiencies. We have to tackle those, and you have to play a part in exposing and tackling those. Now again, this may not be a popular thing to say, and it may get me over at that podium, but I'm not convinced that we have a doctor shortage in Canada either. I don't think we can actually make that claim until we have all health professionals working to their full scope of practice, until we determine the proper division of labor. I think we have to get away from the reflex we have of saying the solution to every problem is more, more, more. Let's just throw bodies at the problem. We've done that, and it hasn't worked so well. Now, while I'm not sure we have a shortage of doctors, I'm pretty convinced that we don't have the mix right. We have about 50-50 general practitioners and specialists in Canada. I think that's skewed way too much towards the specialists, that we have to put a lot more people in general practice. To manage the... Oh. Thank you. You can clap at things you like. You can throw buns at the things you don't like. I don't mind. I'll take them both with equal vigor. To manage the care of Canadians, particularly older Canadians with a multitude of chronic illnesses, we need a lot more generalists. And we need to value family medicine as a specialty. You know, I'm making this division because that's how it's done in the statistics, but family medicine is a specialty. And I think we have to recognize that financially and otherwise. Now, why do we need more generalists? Well, we need physicians who treat the whole person and who treat them in the context of where they live, in their communities. That's what community care is all about, and that's what patient-centered care is all about. Now, I don't want to leave you with the impression that I'm saying family medicine is a synonym for primary care, because it isn't. GPs have a role to play in primary, secondary, and tertiary care, and we often forget that. The way that GPs have been shut out of hospitals, essentially reduced to the role of visitors, and often suspect visitors, is shameful, and we shouldn't tolerate it. It harms the continuity of care. But in the future, family doctors will have to play a much more clearly defined role in primary care, in following patients throughout their care journey. They have to become, along with their team members, the front door of the system. The third big change that's coming down the pipe is a shift to patient-centered care, and I've made a couple of allusions to this already. Now, this is a term that's tossed about to the point where it's also become empty rhetoric. But I think it's something real. So let me state what I think patient-centered care means. It means getting care that's high quality, prompt, safe, respectable, and affordable. I think for $200 billion a year, we should be able to deliver that to every single Canadian. Patient-centered care means doing things first and foremost for the benefit of the patient, for the consumer. And I don't think consumer is a dirty word. We don't do a very good job of customer service in Canada. Our customer service sucks, let's face it. Now again, I want to stress I'm not saying care is bad. It's not. Family medicine is in large part about relationships. It's about trust, being trusted by the patient. The vast majority of doctors do well with this one-on-one care. That's the important stuff. What we don't do well is everything else that surrounds it, before and after the visits. Scheduling, waiting, referrals to labs, waiting, referrals to specialists, waiting, follow-up results, waiting, transferring people to home care or long-term care, more waiting, the ability to get information. These are all things we do badly, and you may have noticed a theme there called waiting. No other system in the world tolerates the waits we have, and Canadians have to stop tolerating. We need to make the journey of care, if you'll forgive me using that hackneyed expression again, we have to make it more seamless. That's what good customer care is. Right now, we don't make it easy at all, especially for people with multiple conditions. We need to do a better job of centralizing services and coordinating care and helping people navigate the system. These are all the big challenges that await us in the near future. Now, the last trend I want to touch on before wrapping up is funding. Funding is going to change in a couple of pretty fundamental ways. As I mentioned before, the only way to make significant savings is by reducing labor costs. No politician will say that in as many words, but that's what they want to do. Now, the easiest way to bring about changes like those is to incentivize them. So how do you spend more to bring about less spending? There's the dilemma. So what are we going to see policymakers try in the future? Well, I think we're going to see a lot more incentives to get people into primary care, both family docs, nurse practitioners, etc. And we're going to see disincentives to specialty care. I think we're finally going to tackle some of the absurd fee schedules, like ophthalmologists being paid hundreds of dollars or thousands of dollars for cataract surgery that lasts 10 minutes, not 2 hours anymore. So those things are going to be tackled, and it'll be ugly. But labor costs are going to be the tough one. In recent years, physicians have done very, very well. They've in fact become the principal cost driver in the health system. Spending on physician services has greatly outpaced drug spending, for example, in the last 2 years. There have been 5,000 new physicians added to the roles in the last 5 years alone. Now, we haven't dealt with waits because they're not properly distributed, but the bodies are there. So there's going to be all kinds of attempts to change funding models. Now, blended funding, a mix of fee-for-service, capitation, salary, etc., is going to continue. That trend is going to accelerate. But governments are also going to try to be less generous with their money. We're going to see a leveling off, even a freeze in physician pay. We're also going to see experiments with results-based payments, which is very much in vogue in Europe, in hospitals and both at the practitioner level. And I think as budgets tighten up, we're also going to experience something that we never have experienced before in Canada. And that's going to be unemployed and underemployed physicians. That's a new reality that people who are graduating today are going to have to look at. Now, the one glimmer of hope you can take from that as family docs is it's going to be a lot easier to fill your locums. But overall, it's going to cause a lot of trauma in the system. Now, the other big funding change that's going to come is what Medicare pays for. And that's something that we have to attack pretty fundamentally. This battle has been looming for decades, and it's an important one. And it's the only way we're going to fundamentally reshape the system. There are many universal healthcare systems in the world. We'd like to think we're the only one, but we're not. We're just the most expensive one. All of them are more cost-effective than Canada's, and none of them have our chronic wait time problems. Canada is unique in the world in only one regard. We have a bifurcated system of public-private insurance. What does that mean? It means that our public insurance system pays essentially 100% of only two things: physician services and hospital services. And it pays only a fraction of all other services: drugs, home care, long-term care, dentistry, etc. Every other developed country has a much more evenly blended model. They pay about 70 to 80% through the public treasury, and the balance with insurance or out of pocket. We do the same, except European countries do so across the board, not in this bifurcated fashion. We're moving towards that model, and that has important implications for physicians. Practically, it means you're going to have to learn to deal with private insurers, but some stuff is going to be delisted, and you're going to have to expect payments from patients. That's going to be something new, and I think something better. It's also going to allow you to charge more for services that are outside the Medicare basket of services, outside of provincial insurance plans. This is going to be a big adjustment. But that's an important part of your teamwork. Bring in team members who have experience with the private sector, like podiatrists and ophthalmologists or optometrists, etc. That's going to be a key to building teams, is getting people in that can help you with that model and adapting to that model. The other thing that the funding changes are going to bring you is more of a gatekeeper role. And I know a lot of people will shudder at that. But private insurers are going to demand that you justify interventions. And increasingly, so is the public system. And the public system hasn't done that near enough. The relationship has been too open-ended. We're going to have to follow the European model in that regard as well. You have a role, an important role, to play in curbing waste and overtreatment and excess spending. That's going to be the trade-off for more freedom and for higher income. And I think family physicians are going to see higher income when they're recognized more as a specialty. Now, my time is up, so I'm going to sum up very briefly. I'm going to sum up by saying change is coming, long overdue change. The revamp of the health system is going to put much greater emphasis on primary care. As family doctors, you're going to have a much more prominent role, but as part of a team. You're going to make more money, but you're going to have to take on more responsibility. And you're going to have to dabble some in the private sector, like it or not. Now, I hope I've given you a little taste of what's to come so you can prepare. As I said earlier, there's much opportunity, but above all, there's the opportunity to show leadership. And I think that's why you're here in such large numbers. There's a willingness and an ability to show leadership, and the public is looking forward to it from its family docs. So again, I thank you for this honor, and I wish you all the best for a wonderful conference. Merci.